So, in the last video, we kind of finished up everything that had to do with the stomach and proximal duodenum. We looked at malabsorption syndromes. We talked about celiac, lactose insufficiency, everything that's over here, as well as ulcer complications. Now, right now, we're up to this part where basically I'm going to go through a bunch of practice questions related to some of the things that we've talked about so far, as far as esophageal pathologies and stomach pathologies and the proximal colon pathologies. And then there's some questions here that are also going to be for things that are coming up next, such as the notorious inflammatory bowel diseases, Crohn disease, and ulcerative colitis. So, the first question I have here from UWorld: 36-year-old man comes to the office due to a 2-month history of pruritic skin rash over the elbows and knees. The patient has been using skin emollients, but the lesions have not improved. He also has a prolonged history of episodic abdominal discomfort, flatulence, and voluminous greasy stools. Cardiopulmonary exam is normal. The abdomen is soft and non-tender. Skin exam shows a papulovesicular skin rash in groups with erosions and excoriations. What is the most likely seen in this patient? So you're seeing some kind of pruritic skin rash as well as voluminous greasy stools, and that should really ring a bell for celiac, right? So what are you going to see in this patient? You're going to see increased intestinal intraepithelial lymphocytes, which is actually a really interesting answer choice that they chose to put here, because that's one thing a lot of people tend to forget. When you go back to celiac disease, remember that this is a gluten-sensitive enteropathy. This is actually supposed to be some kind of like almost in a sense an allergic response to stuff, right? And they tell you here that you're going to see intraepithelial lymphocytosis. So they literally picked on that as an answer choice rather than anything else they could have chosen. Right? This is one little topic here that a lot of people tend to forget about celiac disease. Of course, looking at the other answer choices would help too, and this one would be the only one that you would see makes any sense. Dermatitis herpetiformis is characterized by erythematous pruritic papules, vesicles, and bullae that appear bilaterally and symmetrically on the extensor surfaces, upper back, and buttocks. The term herpetiformis refers to the resemblance of clustered vesicular lesions to those seen in HSV herpes infections. Histologically, dermatitis herpetiformis is characterized by microabscesses containing fibrin and neutrophils at the dermal papillae tips. The overlying basal cells become vacuolated, and coalescing blisters form at the tips of involved papillae. The pathogenesis of dermatitis herpetiformis involves the formation of IgA antibodies against gliadin or gliadin tissue transglutaminase complex in the intestines. These antibodies appear to cause clinical disease by cross-reacting with epidermal transglutaminase. DH is strongly associated with celiac disease, which is characterized by increased intraepithelial lymphocytes, a variable loss of villus at height, and crypt hyperplasia, leading to clinical features of malabsorption. So up here, this is basically showing you extensor surfaces of dermatitis herpetiformis, which is directly related to celiac disease, right? So notice how celiac disease, which is definitely high yield, you can have a question that literally starts off with something dermatologic, right? This patient presented because of her itchy skin rash, and then the question changed gears to something about GIT related stuff. And this is a table that really tells you all the symptoms that are either gastrointestinal or extraintestinal, and how you come to the diagnosis, right? And the increased intraepithelial lymphocytes are a big part of that. The flattened villi are another part of it, where when you do the D-xylose test, remember that to absorb D-xylose, you need a good functional mucosa. If the mucosa is damaged, then you're going to end up just pooping out all the xylose you ate. If the mucosa is working fine, you'll absorb the D-xylose, and then it'll get into the kidneys and you'll pee it out. Right, so really important to remember that test. Second question here, also from UWorld, says a 27-year-old woman undergoes laparotomy for right lower quadrant pain and is found to have an inflamed terminal ileum. The involved segment of the intestine is removed, and the lesion observed on light microscopy is seen in the image. Image shows a non-caseating granuloma. So I'm not showing you the image, but I'm telling you what's in it. So you're seeing a non-caseating granuloma, and the question is something about the terminal ileum. Which of the following cell types most likely mediated the lesion? And you have to know that when you see a non-caseating granuloma and the issue has something to do with the terminal ileum, that's immediately Crohn's disease, right? It can't be ulcerative colitis. Ulcerative colitis doesn't have granulomas to it. Crohn's disease does. It's a disease, not just an inflammation like colitis is, and this is going to be the next topic we're going to be talking about in this video. So this is just a prequel to that. You need to remember that Crohn's disease is due to Th1 cells, which, if you remember your immunology, then you would remember that Th1 cells are the ones that are usually involved in any kind of macrophage-related granuloma formation. The ileal inflammation and non-caseating granuloma are consistent with Crohn's disease. Macrophages release TNF-alpha and pro-inflammatory cytokines that promote macrophage migration and Th1 differentiation. Th1 produces interleukin-2 and interferon gamma, which further activate macrophages. Th17 are a subset of Th1 cells and contribute to the cell injury seen in Crohn's disease. In comparison, ulcerative colitis is related to Th2 cells, which produces interleukin-5 and 13, which contribute to inflammation and damage of the intestinal mucosa, right? Colitis is just an inflammatory thing. So we're going to see more of that when we get to your inflammatory bowel diseases. Now here on this page, these are mostly all AMBOSS questions, and then we have this one that's from UWorld. So let's take a look at them. An otherwise healthy 56-year-old man comes to the physician for a 2-year history of recurrent upper abdominal pain and fullness that worsens after meals. Urea breath test is positive, and endoscopy shows diffuse mucosal atrophy and patchy erythema but no ulcers. A biopsy from which of the following areas is most likely to yield an accurate diagnosis? So you need to know that when you see a urea breath test that's positive, that's going to be related to H. pylori. And H. pylori, we already talked about, causes first, A before B. So H. pylori does the antrum and then the body, whereas autoimmune starts with an A, so autoimmune affects the body first, right? So this is going to be in the pyloric antrum, right? Remember, this is called the pyloric antrum because that's where the pylorus kind of goes to, or sorry, not the pylorus, the H. pylori goes to. So the answer was just your gastric antrum. You would check the gastric antrum and you would get a positive biopsy. This patient with recurrent upper abdominal pain and fullness after meals, positive urea breath test, and an upper endoscopy finding of diffuse mucosal atrophy and patchy erythema likely has atrophic gastritis caused by Helicobacter pylori. Chronic atrophic gastritis due to H. pylori infection begins in the gastric antrum and then spreads to the other regions such as the fundus and body. Biopsies from the gastric antrum are therefore most likely to yield an accurate diagnosis because atrophic changes and H. pylori infection load is greatest at this site. Gastric maltoma is a potential complication of H. pylori infection. In contrast to H. pylori-induced atrophic gastritis, the gastric fundus and body are primarily affected in autoimmune atrophic gastritis, which can present similarly, but the urea breath test would be negative, and the other features suggestive of autoimmune disease, such as pernicious anemia, autoimmune thyroiditis, would also be present in that patient. Patients with atrophic gastritis have decreased gastric acid secretion, so hypochloridia, with a secondary increase in gastrin levels, right? You have more gastrin, but no acid secretion. Next one, 79-year-old man with aortic stenosis comes to the emergency room because of worsening fatigue for 5 months. So right now it looks like a question that's going to be related to cardiovascular. During this time, he has also had intermittent bright red blood mixed with his stool. So now we have some kind of GIT issue. And you should keep in mind that any time a really old person has blood in their stool, you really want to think of a colonoscopy, think of colorectal cancer. He has not had any abdominal pain or weight loss. Physical examination shows pale conjunctivae and a crescendo-decrescendo systolic murmur best heard at the second right intercostal space. So the paleness is a sign of the anemia, and the crescendo-decrescendo murmur is the correct sound you would hear for aortic stenosis. The abdomen is soft and non-tender. Lab studies show a hemoglobin of 8, which is low, a mean corpuscular volume of 71, which is pretty much a sign of iron deficiency anemia because this is microcytic anemia. Colonoscopy shows no abnormalities, which of the following is the most likely underlying mechanism of this patient's bleeding? So, colonoscopy, when you do a colonoscopy, the only abnormality you're really going to see most prominently is going to be any kind of polyps, right? And this patient apparently has no polyps. So, without the polyps, all you're basically understanding is that there's no risk of colorectal cancer right now. So where is he really bleeding from? Well, he's still bleeding from the colon. You would find tortuous submucosal blood vessels. Right, so this is a little bit of a question which is also kind of unorthodox, because this isn't really how this topic is usually tested, but it's still a fair way of testing it, and it totally makes sense. So basically what's happening here is this patient has evidence of a chronic episodic lower GI bleed without a mass or diverticula on colonoscopy, right? There's no diverticulosis happening. We're going to learn what that is soon too. And there's no polyps. His murmur is consistent with aortic stenosis, which is commonly associated with the condition causing his GI bleeding, and aortic stenosis, however, is also associated with just being really old, right? Because there's calcification of that valve. Tortuous and dilated submucosal blood vessels are characteristic of angiodysplasia, which is associated with aortic stenosis, as seen in this patient. The dysplastic vessels in angiodysplasia are typically located in the cecum and the semicolon, and classically cause episodic and self-limiting bleeding. Colonoscopic visualization is challenging, and definitive diagnosis usually requires angiography. Other conditions associated with angiodysplasia include von Willebrand disease and end-stage renal disease. So this is a really interesting question, basically on the topic of angiodysplasia. We're going to see a lot more of that later on, especially in hem-onc, and I believe in neurology as well. But generally speaking, when you have a patient that comes in like this with bleeding and colonoscopy is perfectly fine, and they have aortic stenosis, you should immediately think of angiodysplasia and just think of tortuous blood vessels. The other thing about this question is that the other answer choices didn't really make any sense. They had nothing to do with bleeding in feces, so it was pretty easy to pick this answer choice and just go with it. But definitely a very unorthodox way of testing on something, and angiodysplasia is just one of those topics that you can have a question about it in so many different ways. Here we have a 53-year-old man who comes to the physician because of a 2-week history of fatigue, generalized itching, and yellowing of the eyes and skin. He underwent a liver transplantation because of acute liver failure following alpha-amanitin poisoning 1 year ago. So alpha-amanitin is something that was discussed in biochemistry. Physical exams showed scleral icterus and abdominal distension with shifting dullness. A liver biopsy specimen shows decreased hepatic duct density. Further histological examination of the liver biopsy specimen is most likely to show which of the following findings. And the correct answer was interstitial fibrosis, which about 45% of people got, so that was good. But 30% of people chose graft vessel vasculitis, so we have to look at that too. This patient with a history of liver transplantation is now exhibiting features of liver failure, right? He has jaundice, pruritus, fatigue, ascites. Biopsy shows ductopenia, which indicates vanishing bile duct syndrome. And vanishing bile duct syndrome is actually a real thing. Signs and symptoms of liver failure 1 year after liver transplantation suggest chronic graft rejection, which occurs due to reactions at both the cellular and humoral level in response to donor peptides. The ensuing inflammation leads to interstitial fibrosis, atrophy of the parenchyma, vascular smooth muscle proliferation, and ductopenia, as seen on this patient's biopsy. So why was graft vessel vasculitis wrong? Well, you need to remember from immunology the 4 different types of chronic rejection and what happens with chronic rejection depending on those 4 types, those 4 different organs, right? Whether it's the kidney, lungs, liver, and I think there was one more for, I can't remember what the last one was, but we'll go back and look at it actually. And you need to know what each one actually looks like. So let's go back and revisit that real quick before we move on so we can get an understanding of what happened with this patient. So, graft rejection, vaccination, blood transfusion, okay, right here. Transplant rejection. So in chronic, see there's 4, in the heart, right? 4 different types of chronic rejection. If you have rejection of a lung transplant, that leads to obliteration of your bronchioles, right? Bronchioles are destroyed. If you have a heart transplant that's not working, you're going to have inflammation, and the most notorious inflammation of the heart is just atherosclerosis, right? Whatever heart this patient was given will probably already have some level of atherosclerosis happening, and the diet of the patient might not be good, but all that inflammation will immediately lead to atherosclerosis much earlier and much quicker than atherosclerosis usually occurs. In chronic kidney rejection, you get graft nephropathy, right? So just normal type of renal nephropathy. With your liver transplant, it has nothing to do with blood vessels. It's actually related to the bile duct, and you get vanishing bile duct syndrome. Right, so the question we're looking at right now is vanishing bile duct syndrome, which is relevant right now because in GIT, the liver is a really big deal. Right, so right here, with this person presenting with this, almost specifically GIT type of liver issue. Oh no. Why did the colors change? That's so weird. Excuse me, let me fix that real quick. That's a little problem with this app where if I do kind of open up to edit something, sometimes the color edits go away. I don't know why it does that. But I keep the answer choices a different, the answer explanations a different color, so it's a little easier to navigate myself. Let me fix that right now. Okay, so anyway, where were we? This question right here. So this guy with his liver transplantation is today presenting with itching, fatigue, right? All of this stuff 2 weeks later. But his liver transplantation was a year ago, right? 1 year ago. So that means that whatever is happening to his liver must have been pretty chronic, because anything acute would have happened much longer ago. Physical exam is showing all these symptoms of his liver not working well at all. And ascites especially a big deal, because when you have ascites, that means that something's wrong with the functional unit of the liver itself. So now, when you have the ductopenia and all this stuff, once you figure out that this is chronic rejection of the liver, you immediately think of vanishing bile duct. And interstitial fibrosis is the most obvious answer to pick, right? The Edo cells are going to act up, and you're going to get fibrosis because of all that inflammation. Graft vessel vasculitis is acute rejection. Acute rejection occurs within 6 months of transplantation and is due to antibody formation against the donor MAC. It's characterized histologically by vasculitic changes of the graft vessel and an interstitial lymphocytic infiltrate. The timing of the patient's symptoms is inconsistent with acute rejection, as is the biopsy finding of ductopenia. Right, it's a really nice revision of pretty much chronic graft rejection. This next question was related to the two pictures we're seeing down here. Make sure I don't click on that. Okay. So a 61-year-old man comes to the physician because of a 6-month history of epigastric pain and a 9-kilogram weight loss. He feels full and bloated even after eating small portions of food. His hemoglobin concentration is 9.5, which is low, with a mean corpuscular volume of 78, which indicates microcytic anemia, usually due to IDA, iron deficiency anemia, at this age of 61. Test of stool for occult blood is positive, so he's bleeding in his feces. This long word is just basically endoscopy. So esophageal gastroduodenoscopy is just an endoscopy in a sense. Shows a 2 centimeter raised lesion with central ulceration on the lesser curvature of the stomach. Right, so the lesser curvature, which is supplied by the left and right gastric arteries. Histologic examination of the gastric biopsy specimen from the lesion is most likely to show which of the following. And the answer was gland-forming cuboidal cells. You have to remember that the stomach is mostly cuboidal cells, and we did all the various histological images already, right, when we were doing GIT anatomy. So they go on to explain to you that the histological image below of gastric adenocarcinoma was provided in the explanation, and that's what this patient has, right? This is very clearly gastric cancer. He has epigastric pain, weight loss, early satiety, so he's not eating much, microcytic anemia. In a patient with a suspicious lesion in the lesser curvature of the stomach should raise suspicion for gastric cancer. Adenocarcinoma is by far the most common type of gastric cancer. Gland-forming cuboidal cells are seen in adenocarcinoma, which is the most common type of gastric cancer, accounting for about 90% of cases. The endoscopic finding of a suspicious ulcer confined to the lesser curvature is consistent with the intestinal type 1 gastric adenocarcinoma, which is characterized by aggressive local spread and typically metastasizes to the liver and regional lymph nodes. Risk factors include chronic H. pylori infection, smoking, and chronic gastritis. 32% of the people, right, chose mucin-filled round cells, which would be correct for diffuse gastric cancer, but that's not what this patient has. Mucin-filled round cells with a peripherally dislocated nucleus are known as signet ring cells, which would suggest signet ring cell carcinoma. A patient with this type of cancer could also present with weight loss, epigastric pain, and bloody stool. However, endoscopic examination would typically reveal diffuse involvement of the stomach wall, and you would get the plastic, right, the linitis plastica, the leathery stomach, rather than a single ulceration confined to the lesser curvature. Right, so this question does a really good job pretty much breaking down the difference between your two types of gastric cancer that we discussed on this page right here. Right, intestinal, which is going to have this one kind of thing like this, and we spoke about this, right? An ulcer with raised lesions, usually on the lesser curvature, right? If you have diffuse, the word itself means it's the whole stomach, and the whole stomach wall becomes thickened and leathery. So that's what the linear dysplastica is. And this is the only time you see these two things happen, which is basically your signet ring cells. Right, it's a really nice question to pretty much help you differentiate between the two. Here we have the histological stuff. So this left one is your gastric adenocarcinoma, which is the intestinal type. This right one is gastric adenocarcinoma with signet ring cells in the diffuse type. And you can see there's a bunch of big round cells here, right, with the tiny dot at the rim of each one of these, which is basically your peripherally dislocated nucleus. All right, so that's a big difference between the two. Last two questions here. First one is UWorld. 56-year-old woman comes to the office due to a 3-month history of excessive fatigue along with progressive numbness in both feet. Her sleep is adequate and she eats a normal diet. She has a history of hypothyroidism that was diagnosed following a pregnancy 20 years ago. Her only medication is levothyroxine, and she does not use drugs, tobacco, or alcohol. Physical exam shows mucosal pallor with a flat, shiny tongue. Neurological exam finds diminished vibratory sensation in both feet. TSH is normal. Peripheral blood smear shows multinucleated neutrophils. What is the most likely increased in this patient? Right, and then your answer choices, and I put them all here, were gastric acid production, gastrin release, intrinsic factor production, secretin release, glucagon, or VIP. Now this isn't a glucagonoma, nor is it a VIPoma, so you can cancel out those last two. The answer here was gastrin release. 36% of people got it correct, but 40% chose intrinsic factor production, which really doesn't make sense, right? She actually has pernicious anemia because she doesn't have intrinsic factor. So how could you pick intrinsic factor production? I really don't know. I'm not sure how those 40% of people thought it might be that as the correct answer, but it is what it is. She most likely has pernicious anemia due to autoimmune destruction of gastric mucosa, and the lack of vitamin B12 is why she has multinucleated polymorphic neutrophils as well. So destruction of gastric mucosa with a history of autoimmune thyroiditis, right? So she also has another autoimmune thing. The reason she's taking levothyroxine is pretty much just Hashimoto thyroiditis. Over time, the chronic atrophic gastritis caused profound hypochlorhydria. So A is wrong. Gastric acid production is wrong. It would be low acid production. The loss of intrinsic factor secreting parietal cells leads to low production of intrinsic factor and the loss of B12. Pretty much these people end up losing their parietal cells, so they can't make acid, nor can they make intrinsic factor. They can't make either one of those things. And now that they can't make either one of those things, because in pernicious anemia your autoantibodies killed off your parietal cells, they end up having more gastrin release, right? Pretty much it's like a feedback thing. Since you're not making the product, you release more hormone in attempts of making the product, but it's not going to work. Right? So you keep making more and more gastrin, but no acid is being released. And that's what happened to this patient. Last question here, 43-year-old man. This is a really interesting question because this is about what's in the red, the systemic mastocytosis. I've never really heard of it, but this is actually a GIT question. So I had to make sure I put it here just in case one of you see this kind of stuff in your NBME. A 43-year-old man comes to the office with a several-month history of fatigue, rash, and abdominal cramps. His rash is worse with rubbing or scratching, and he has diffuse itching after hot showers. He's frequently dizzy and lightheaded after prolonged standing and had an episode of syncope while working in the hot sun. He used to be healthy and physically active but had to reduce his normal activity. He does not smoke, drink, or do drugs. His vital signs are normal. Skin exam shows maculopapular rash. Skin biopsy, now this is the weird part, skin biopsy shows large clusters of mast cells that are positive for KIT, which is a CD117 proto-oncogene. I've never heard of it. What additional findings are most likely present? And then you have a bunch of answer choices, of which gastric hypersecretion was actually the correct answer. And I had no idea. I actually could not pick an answer from this. 32% of people chose gastric hypersecretion, and 33% chose pancreatic endocrine tumor. Gastric acid secretion by parietal cells in the fundus and body of stomach is stimulated by histamine-binding H2 receptors and increasing cyclic AMP, acetylcholine-binding M3 receptors to raise intracellular calcium, and gastrin-binding CCK-B receptors to increase intracellular calcium as well. Intracellular calcium and cyclic AMP activate protein kinases and lead to more H+ via the H+ potassium ATPase. In systemic mastocytosis, which is what this patient has, clonal mast cell proliferation occurs in the bone marrow, skin, and other organs. Mast cell proliferation often is associated with mutations in the KIT receptor tyrosine kinase. These cells are characterized by prominent expression of mast cell tryptase. Excessive histamine release from degranulation of mast cells mediates many of the symptoms of the disease, such as syncope, flushing, pruritus, and urticaria. Also, histamine induces gastric acid secretion, leading to gastric ulceration. The excess acid also inactivates pancreatic and intestinal enzymes, causing diarrhea. So basically, what I learned from this question was systemic mastocytosis is this weird disease where you have some kind of almost allergic thing happening, and there's a lot of histamine involved. And anytime you see histamine and excess amounts of histamine being released, you should think of the H2 receptor, where histamine causes more gastric acid release, right? And that's how that was the correct answer. All the other answer choices really didn't have any kind of flow chart where you can come to that, arrive to that answer choice. But gastric hypersecretion you could arrive at by just thinking of how much histamine this guy must be releasing. A really weird question. I can't really imagine anyone ever getting something on this, but it's interesting to know that you need to be able to map things in this kind of way, because your step one could have a question about some other weird disease, like this is about systemic mastocytosis. Yours could be about any other weird kind of disease, and you should be able to map things in the question stem to find what could be leading to something in your answer choices. Alright? Now on the next page comes the notorious inflammatory bowel diseases, Crohn's disease and ulcerative colitis. Definitely high yield, very lovely diseases in the sense that step one loves asking about them because they make such good questions, right? They're both terrible diseases to have. They do make life hell, but they're both diseases that you can live with. They do not kill you, right? You're not going to die because you have Crohn's disease, nor will you really die because you have ulcerative colitis, but they're both definitely very problematic diseases to live with. Crohn's disease is a disease. It's not just a colitis like ulcerative colitis. So when you're thinking of these two, anytime you get a question, really try to imagine, whether or not someone has a disease that's affecting a lot of things or just an inflammation of the colon itself. There are very clear differences between the two diseases. But what makes them hard is that in a question, the question can start from almost anywhere and then slowly make its way to the GIT. And then at that point, you're left with a bunch of little things to pick at and arrive at whether or not this could be Crohn's disease or ulcerative colitis. So let's take a look at each one by one. Crohn's disease affects anywhere from the lips all the way to the end of the large intestine. Right? Any portion of the GI tract, usually the terminal ileum and colon are involved. It has skip lesions and it has rectal sparing. So basically the rectum is never involved, right? The rectum is never involved here. Skip lesions are obviously also obvious because this is a disease, not an inflammation. So that means that you're not going to affect the whole colon, but you might affect certain parts of it, and then in between certain parts are completely normal. Gross morphology involves transmural inflammation. So there's inflammation across the whole wall of your lumen, right? So the whole thing is inflamed. And if you have inflammation of the whole wall, you can rip through it. And when, let's say if these were two different colons and they're touching each other, and there's inflammation in that area, transmural inflammation, the two parts can start connecting, right? Those two parts that have inflammation will start connecting, and you end up getting fistulas, right? So there's going to be fistulas in Crohn's disease where two different parts of your intestine have now made a new connection. There's also something called cobblestone mucosa and creeping fat, and I'm going to show you a picture of that. Actually, we can just go to it right now. So, let me see, creeping fat. This is what they're talking about. So you see how in the middle right here, there's fat that's normally there, right? Now it's kind of wrapping around the whole colon. That's your creeping fat. And you have a cobblestone mucosa. Cobblestone is, you should Google cobblestone. Let me just show it to you, cobblestone. So cobblestone is usually like seen on the floor in many places. Usually some really cool places that you might be visiting. it's kind of like this one, this image right here, right? So that's cobblestone on the floor right there, and that's basically what's happening to the intestine. You see, it's not like smooth like this anymore. It's got this cobblestone kind of thing happening. And that's what they're talking about when they say cobblestone. And the other thing I showed you is what they're talking about when they talk about creeping fat. You also have bowel wall thickening, right? So you can see that this lumen is huge, and now this lumen is very thin because the bowel wall is really, really thick. You can see it doesn't happen in ulcerative colitis. Ulcerative colitis, the bowel does not thicken, right? So the lumen is still big in ulcerative colitis, but in Crohn's disease, the lumen has become really small because your bowel wall got really thick, right? Thickened bowel wall. They're even showing you the histology in this image. So when you do the barium swallow, you see something known as a string sign, right? You can see that in image A right here, right? This is your really thin lumen. That's what the red arrows are pointing at. A really, really thin lumen of the bowel, all right? Linear ulcers and fissures. Alright, so those are just all the different things that you're going to see in Crohn's disease because it's a disease. You have many different manifestations in a disease. It's not just an inflammatory condition, so you don't just see one kind of issue taking place. The other thing, on microscopy, you're going to see non-caseating granulomas and a bunch of lymphoid aggregates, all of which is related to Th1. Right? You don't see any of that in ulcerative colitis. Ulcerative colitis does not have granulomas because it's just a colitis. Right? Crohn's disease is a disease, and there are non-caseating granulomas here. So what are complications? Well, complications are pretty much related. Complications that are related to both of them are generally malabsorption, malnutrition, and colorectal cancer. Both Crohn's disease and ulcerative colitis can lead to colorectal cancer if they're not being managed. Things that are unique to Crohn's disease are the fistulas, either an enterovesicular fistula where your intestine connected to the bladder. And if you do get that, then you would have recurrent UTIs and pneumaturia, right, which is just going to be really problematic. So you don't want to have any of that. Enterovesicular fistula. You can also have just fistulas between different parts of the colon, right? So like I was showing you, these are two different parts of my colon and they're touching each other and there's inflammation in that area. It's transmural inflammation, so it's going to cause a connection between the two parts of the lumen. You can also get phlegmon, abscess, strictures, and perianal disease. You can get perianal disease, but the rectum is not involved, right? It's really important to make sure you understand that difference too. Perianal disease, but rectosparing. The rectum is not involved. Intestinal manifestations are just diarrhea that could or could not be bloody, right? It doesn't have to be, but it might be bloody. And that's a really dumb thing to say. It doesn't really help you in any way. It would be different if I said that it's never bloody, but this is like, oh, it could be bloody. Well, thanks. That doesn't really tell me anything. Extraintestinal manifestations are mostly, there are some unique ones, but here's the ones that are mostly shared. So both Crohn and ulcerative colitis could have a rash. What kind of rashes are we talking about? Well, first off, you have your pyoderma gangrenosum, which looks like this image, right? Pyoderma gangrenosum. You could also get erythema nodosum, which looks like this image, and this is painful. When you touch it, it's painful. This one is obviously also painful and just looks really messed up, right? Gangrenosum, so gangrene, so it's kind of like dead tissue. And this is pretty much happening extraintestinally, so this is anywhere on your body, really. You can get eye inflammation, so uveitis, episcleritis. You can literally get a question that starts off by talking about uveitis first, but then changes gears to become a GIT question. And lastly, you can get osteostomatitis, which is basically oral ulcerations, right? Oral ulcerations. This is actually something that's shared with both. So even though ulcerative colitis is mostly just a colon thing, the inflammation is only in the colon, but you can still get oral ulcers. And that would be brilliant to put into a question because it can really throw you off, right? When you're studying, you're thinking, okay, Crohn goes from the lips to all the way to the end of the large intestine, but not the rectum. Ulcerative colitis is only the colon. Then how is the mouth involved? Well, ulcerative colitis could have the mouth involved if they're just talking about ulcers in the mouth, right? Oral ulcers. There's no inflammation in the oral area, though. And, of course, arthritis, right? Peripheral or spondylitis. What's unique to them? Well, Crohn's disease is going to have kidney stones, usually calcium oxalate kidney stones, and they're going to love testing you on this. A lot of times questions are really going to just be about renal stuff and kidney stones and etc., and then somehow the question turns gears and becomes a GIT question. You could also get gallstones, right? Because remember in Crohn's disease, your terminal ileum is involved, and you're not going to be able to do reuptake of anything there. The last thing is maybe positive for anti-Saccharomyces cerevisiae antibodies, ASCA. This I've never really seen a question on, to be honest, but if you do see it, if you do see the anti-Saccharomyces cerevisiae antibodies, it should ring a bell for Crohn's disease, and then that's it. You really don't need to think any more about it. So that's, two of the main things. Now let's take a look at some of the notes here. So we talked about the extraintestinal manifestations. Erythema nodosum is an inflammation of the fat cells under the skin, resulting in tender, which means painful, red nodules or lumps that are usually seen on both shins. Right, you can see it. It's on both of the legs right here. Pyoderma gangrenosum is a condition that causes tissue to become necrotic, causing deep ulcers that usually occur on the legs and lead to chronic wounds. Up here I talk about the impaired bile acid absorption, which is related to the kidney and gallstones. Impaired bile acid absorption in the terminal ileum leads to loss of bile acids in the feces with subsequent fat malabsorption, which means you also lose your fat-soluble vitamins in these patients. And a lot of Crohn and ulcerative colitis questions can start off with symptoms of a missing vitamin, either vitamin A, D, K, or E deficiency. Lipids then bind calcium ions, but oxalate is supposed to bind calcium ions. Now, there's free oxalate that didn't bind the calcium ions, so it all get absorbed and it makes urinary calculi. They also lose fat-soluble vitamins and get gallstones. Right, so the reason you're getting calcium oxalate stones is because your lipid, right, the lipid that you lost was supposed to bind to the oxalate, but you don't have it anymore. So now calcium binds to it, and calcium oxalate makes kidney stones that are not going to be good. They're going to be very painful for you. Alright, so anytime you get a question on calcium oxalate kidney stones in a Crohn's disease patient, it's related to impaired bile acid absorption. Alright? It's actually occurring because they lost the lipid that was originally supposed to bind the bind the oxalate. On the other half of this page, we have ulcerative colitis. So this is a colitis. It affects the colon, and the rectum is always involved, right? Always with rectal involvement. The only thing you can have in anywhere in the entire GIT is the oral ulcers, right? The oral ulcerations. That's it. These oral ulcerations are something you could have in ulcerative colitis. It doesn't mean that it's Crohn's disease just because it's oral, but the inflammation is only going to be in your colon. So you can have mucosal and submucosal inflammation, but it's not going to be transmural. It doesn't go through the wall, so there won't be any fistulas in ulcerative colitis. You'll get friable mucosa with superficial and or deep ulcerations. Compare the normal with diseased. There's going to be a loss of haustra. So you see how this is normal, and then look at the diseased one. Right, you're seeing ulcerations, a lot of different ulcerations, but none of these are going to be fistulas, right? And it's not just one ulcer either, it's a bunch of inflammation all over. The loss of haustra is pretty important. So you get something called the lead pipe appearance on imaging. So the haustra, let me see, I should have a picture of that too. Loss of haustra. They didn't show it here. Yeah, I don't have it. So basically the haustra is kind of like this thing here, this line that's in the middle, right? It's following all the way, but then you lose it. I don't know why they're still showing it in this image here. I guess they kind of forgot to Photoshop it out, but you won't have it there. And when you lose the haustra, you have a lead pipe appearance. It's just going to be very circular, very thin and circular lumen for ulcerative colitis patients. Let me see, I should be able to find something online real quick. Loss of haustra, ulcerative colitis. Images. Oh, okay, there you go. That's pretty good. So this is usually something you can see on x-ray, so that's why a bunch of x-rays are popping up, but this image here does a pretty good job. So you see how the loss of haustra, so you have tubularization, right? It's a very weird, and then the rest of it is all very megacolon-ish, right? And when you look at it in x-rays, right, this is kind of what's happening. Right, so this is a patient with ulcerative colitis. This is also a patient with ulcerative colitis, right? This thing that you're seeing here with the squeezing in, right, it looks like a bunch of little like toes that are sticking out, right? Stubby toes that are sticking out. That's actually a big sign of ulcerative colitis also. So as we go on, we're going to see that ulcerative colitis has toxic megacolon as well, and you get that stubby toe thing that I just showed you as well. On microscopy, you're going to see crypt abscesses and ulcers, right? Because obviously there's a bunch of ulceration that's happening. A crypt abscess is like this. So you see how in a normal colon you have these crypts, right? And in the crypts you have a bunch of goblet cells. And we saw this when we did the histology in GIT anatomy earlier. Now, within those crypt, you have absence of goblet cells and a distortion with abscesses. You see how there's a bunch of micro abscesses in there? Right? There's an abscess here, there's an abscess here. That's what the crypt abscess is about. And you can see that on histology too. It's not going to look as nice as it originally did. You're going to see something is infiltrating and sitting inside those crypts, and it wasn't supposed to be there before. So that's the pretty unique thing about the microscopic morphology of ulcerative colitis. There will be bleeding, but there's no granulomas, and this entire thing is Th2 mediated. It's an inflammation. And we talked about that earlier, right? We just did that question up here. This question was the one that kind of made you understand Th1 versus Th2 and the whole immunology of Crohn versus ulcerative colitis. So complications, we talked about what's shared, but unique to ulcerative colitis versus Crohn, ulcerative colitis is going to have fulminant colitis, a toxic megacolon, and perforation. And what I just showed you earlier was the toxic megacolon. The colon is just really, really huge. You will always have bloody diarrhea with ulcerative colitis. Like, it cannot be ulcerative colitis if the patient does not have bleeding. So this is pretty valuable information, right? And at that point, you can probably go ahead and pick Crohn's disease. Ulcerative colitis is also related to PSC, primary sclerosing cholangitis, and P-ANCA. Right, so P-ANCA is a big deal. We're going to see P-ANCA is also related to PSC, and later on when we get to PSC, you'll learn that PSC, primary sclerosing cholangitis, has high IgM, and it's a disease of the bile ducts that causes inflammation and obliterative fibrosis of the bile ducts of the liver, leading to hepatocirrhosis and liver failure. So you can actually have a question that starts off by talking about primary sclerosing cholangitis, obliterative fibrosis, talking all this about the liver and stuff, and then all of a sudden it becomes a Crohn's disease versus ulcerative colitis type of question, and you have to be able to understand and remember that things that are happening to the liver lead to colitis. If it's things that are happening to the kidney, that's the one that's related to Crohn's disease, right? Treatment-wise, you just have various types of medications that are good for, autoimmune stuff, but none of it really fixes it. There's no cure for either one of them, but you just do a lot of supportive things, right? So you can see for Crohn's disease you have a bunch of monoclonal antibodies, corticosteroids, over here again mesalamine, mercaptopurine, a bunch of just anti-immune medications. But generally speaking, for both of them, you usually resect portions of the colon. Especially ulcerative colitis. Since ulcerative colitis is continuous, you can take that entire segment that has the ulcerative colitis and just take it out. And you usually extend a little more before and after the segment that has the colitis, so that if it was spreading, you would get that area out too. And when you do that, you have to remember that depending on what part of the colon you took out, this patient is now going to need IV supply of whatever that area was supposed to absorb. So if you took out the ileum absorbs vitamin B12, so this patient is now going to need IV vitamin B12. All right. So that's the main difference between the two. There's one question right here. This one says, a 30-year-old male with ulcerative colitis presents with abdominal pain and bloody diarrhea. He's non-compliant with treatment and vitals are 102F, blood pressure is low, and pulse is 130, which is very high. Patient has dry mucous membranes and marked abdominal distension with tenderness without rebound. So obviously now the patient has toxic megacolon, and the next step in workup is to do a plain abdominal x-ray, right? So I couldn't fit the whole question here, so basically the question probably was, what should be the next step in the workup? And looking at everything that's wrong with the abdominal distension and all of that, he must have toxic megacolon. The way you look at this is just by doing an abdominal x-ray. The other answer choices were like do CT, MRI, blah, blah, blah. But you just need to remember, if you're just trying to look at the colon and stuff, a simple abdominal x-ray actually sees it all. On the next page, there's one more question right here too, so let's take a look. And then this image basically comparing Crohn versus ulcerative colitis in terms of histology. So this question says, a 34-year-old man is evaluated for easy bruising. right? Easy bruising. He says even minor trauma causes a bruise, and he has been experiencing fatigue, poor appetite, and dull pain and stiffness in his lower back and joints at night. He has a history of Crohn's disease that required partial bowel resection a year ago. So they're being nice here. They already told you he has Crohn. 3 months ago, he was treated with oral antibiotics for a perianal fistula. His mother died of colon cancer when she was 56. Physical exams show several large ecchymoses on his lower extremities. What is the most likely diagnosis? So this guy is kind of showing you symptoms of losing vitamin K, right? You always want to think of fat-soluble vitamin deficiency anytime you have some kind of a Crohn versus ulcerative colitis question. And the most likely diagnosis here with Crohn's disease would be bile acid malabsorption at the terminal ileum. Bile acids are necessary for absorption of fat and other nutrients. Bile acids are reabsorbed in the terminal ileum, recycled in the liver, and reused. When it is inflamed, the terminal ileum, when it's inflamed or resected, bile acids are lost with feces, leading to deficiencies of fat-soluble vitamins. The loss of vitamin K is causing this patient to have coagulation disorders, resulting in easy bruising. 30% answered correctly, but 38% chose immune thrombocytopenic purpura, which really didn't make sense because they told you it's Crohn's disease, but also because platelet abnormalities usually cause petechiae, right? ITP is a platelet abnormality, and when we get to hem-onc, we're going to see the difference between platelet abnormalities versus coagulation disorder abnormalities and such. A platelet abnormality would just have tiny bleeding on the skin, petechiae, not what this patient has, which is easy bruising due to vitamin K deficiency. So on the next page, we're just looking at a bunch of images, like this one over here, right? This is showing you Crohn's disease, and this big yellow section is basically showing you the non-caseating granuloma. Right, so high magnification, green overlay at top, this tiny green overlay up here shows infiltrating neutrophils, and the yellow overlay shows non-caseating granuloma. These features indicate transmural inflammation characteristic of Crohn's disease. Right, this one here is showing you the various crypts. So in this image, if you get an image like this, remember you see these two images here, they're both looking at the same exact thing but from different angles. One of them, so imagine the villi are like this. If you look at it from the front, it looks like the image on the left. But if you look at it from the top, then you just see a bunch of tiny holes, and that's what you're seeing here. Right? So this here is looking at those crypts from above. So we can see inside the crypt, and inside the crypt, none of them should have anything, but this one does. So when you see a crypt abscess, that's a sign of ulcerative colitis, right? Very tiny thing to notice, but as soon as you notice it, it gives you the diagnosis. So it's a very important thing to notice. We understand this image where basically you either have skip lesions that are involving the small intestine and different parts of the large intestine, or a continuous lesion, as seen in ulcerative colitis, right? And also, of course, ulcerative colitis is always going to be continuous and always going to involve the rectum, so the terminal ileum is always involved, right? It's always basically starting at the rectum and then going upwards, and you're trying to figure out how far upwards did it go. Whereas here, the rectum is never involved, but different parts of your colon is being involved, or are being involved. This is the basic plain abdominal x-ray showing you toxic megacolon, right? Toxic megacolon due to ulcerative colitis. Here's another image, another question. So this one says, a 33-year-old man with a 2-year history of Crohn ileocolitis comes to the clinic with left-sided flank pain that started in the morning. So as soon as you hear left-sided flank pain, you want to start thinking of kidney stones going into the ureter. The pain is an 8 on a scale of 0 to 10 in intensity and is characterized as sharp. The pain is also colicky and radiates to the left groin. He has no nausea or vomiting. He's in moderate distress and has trouble lying still during the exam. Urinalysis shows hematuria because basically imagine a tiny pebble going through your ureter, just ripping it into shreds. A day later, he passes a urinary stone. So it hurt like crazy as it went down the ureter, finally got to the bladder, and then you were able to pee it out. And it probably also hurt his penis as it came out. Abdominal imaging reveals several additional kidney stones, so he better get rid of those before those enter the ureter and he goes through all this pain one more time. What is the most likely underlying cause of his kidney stones? And it's pretty obvious. It's obviously due to his Crohn's disease. And what does Crohn do? Crohn makes you lose your fat. Once you lose the fat was supposed to bind the oxalate. It couldn't. So calcium bound the oxalate and you absorbed it, and now you have calcium oxalate kidney stones. Right, so Crohn's disease has impaired fat absorption due to terminal ileum not being able to reabsorb bile acids. In a healthy bowel, dietary calcium binds dietary oxalate, producing insoluble calcium oxalate stones that are eliminated in feces. But in Crohn, calcium forms salt complexes with the excess fat in the intestinal lumen and is unavailable for complexing with the oxalate. Oxalate absorption is increased and filtered into the urine, promoting oxalate kidney stones. And that's also going to be calcium oxalate kidney stones, right? So you're seeing two different mechanisms of how you can get calcium oxalate kidney stones, and it's never good news for you because it's going to be painful, it's going to hurt like crazy, and this patient usually what you have to do is probably surgically get rid of the stones because there really isn't an easy way to dissolve it, and it's going to enter the ureter and it's going to be painful every time it enters. Now that pretty much wraps up all that big deals. In the next video, I'll go into all of this and we'll look at the diverticulosis. We'll look at the different parts of things that can go wrong with the rest of your colon. And I think that should be it for the intestinal manifestations, because after that, once we wrap up our other intestinal disorders, we'll finally look at polyps and colorectal cancer and other organs, right? Because we'll be done with all of that. We'll finally start looking at our cirrhosis, right? We'll be finishing up the liver and then the pancreas, and that wraps up GIT pathology. So in the next video, we'll continue on after the Crohn versus ulcerative colitis from here. All right. So thanks a lot for joining, and I'll see you guys next time.